I wonder what I was thinking. I'm just going to reclaim host there, Samantha, for a second, so I can
Yeah.
make you a co-host. Check you can you still transition through your slides okay?
No, actually.
Okay. Okay, I've made you a host there again to see if that works.
No, I can't. Oh, wait, now maybe I could use it down here. No. Oh, here. Yeah, okay. How do we... Yeah, okay, grand.
Hmm, you're a co-host. I think we'll just give a few more people just joining and we'll get started. Okay, I think that's everybody in. Good afternoon, everybody. Excuse me. And welcome to our April CPD webinar hosted by the Discipline of Radiation Therapy at Trinity College, Dublin. Some housekeeping before we start. So this webinar will be recorded and it will be hosted on the TCD website in the coming days. And just a gentle reminder that your mic and camera are disabled, so you won't be able to use those. But if you have any questions, you'll see a Q&A box popping up. Just pop your questions in there and I'll put them to our speaker at the end of the call. So it's my great pleasure to welcome Samantha Ryan to our webinar today. Samantha Ryan is a clinical specialist radiation therapist and research fellow at the St. Luke's Radiation Oncology Network here in Dublin, Ireland. She's over 10 years experience in radiotherapy. She completed her undergraduate degree at Queen's Margaret University in Edinburgh and her postgraduate studies at the Sheffield Hallam University in the UK. Her work focuses on patient-centered innovation, particularly on surface-guided radiation therapy and head and neck immobilization. She played a key role in the OPEN trial, which was a phase 3 study evaluating open-face mass system with surface-guided radiation therapy, developing practical setup techniques that balance accuracy, efficiency, and patient comfort. Samantha is passionate about empowering radiation therapists to engage in research and is actively involved in mentoring initiatives to build confidence, skills, and a strong research culture within the profession. This afternoon, Samantha is going to discuss her experience of the open trial. So, Samantha, I'll hand the floor over to you.
Thanks a million, Laura. So like Laura said, yeah, my name is Samantha Ryan, and I'm the former Slicker Fellow. And this Slicker Fellowship was brought about through the St. Luke's Institute of Cancer Research and the St. Luke's Radiation Oncology Network. From my point of view, it was an absolutely amazing opportunity, and it gave me so much. And it gave me an opportunity and a platform to participate, contribute to radiotherapy in Luke's and the research in that area. And our biggest piece of work was the open trial. I'm going to have to apologize that my face is all over this presentation and it's a little bit narcissistic, but there was no one else that would jump in for the photos. So as was a needs must situation throughout this whole trial, you just have to get on with it and jump up on the bed yourself to let the professional photographer come in and take pictures. So apologies, my face is everywhere. So the open trial is a phase 3 randomized control trial comparing a closed versus open face masks systems. So it stands for optimizing patient experience in head and neck radiotherapy. And I started my fellowship in 2023 and I finished the fellowship in 2025. And another fellow, Claire Fitzpatrick, took over from me from there. We're currently writing up the open trial and all the data was collected last April. So where did the open trial come from? And I think I understand that it's mostly radiation therapists on the call. So we're all extremely aware that mask anxiety is a huge problem for radiation for patients undergoing head and neck radiotherapy. And we've like we have a cohort of patient where the ask is huge, the need is massive, and their why for putting on the mask is bigger than anything else. Like if it's a patient is claustrophobic and they sit inside a lift, that's huge for them. But then if they're claustrophobic and they have to put a mask on to get their radiotherapy treatment to prevent their cancer from progressing, that's massive. So they will put up with a lot before they report it. And this is probably conservative estimate to say that 26% of head and neck patients have mask anxiety, but I'm sure no one actually enjoys it. And the distress is a prognostic factor for poorer survival. And often we have all, I'm sure, seen patients where treatment is delayed, hours can go on a LINAC trying to help patients overcome the fear. Psychology are on set, music, we'll try anything and everything. We're crafty, we'll try and get a patient through it. But if there's a way that we can do that without a mask or with reduced masks, it's imperative that we explore that. And that's a quote from a patient: having the mask on didn't worry me until they clamped my head down so I couldn't move. And that sounds scary, but like we want patients not to be able to move. So that is the objective. And well, before I started the fellowship, the groundwork had started on this piece of work. So we before SGRT was even a thought in St. Luke's, there was a smaller scale study looking at unmasking anxiety was the title, a head-to-head comparison of open and closed masks in head and neck radiotherapy. So this was a small study that didn't have imaging pre or post, but it just looked at a mask that had an open face with no SGRT. And it's a feasible option for a patient that literally will not tolerate a closed mask, but it didn't provide the level of setup accuracy that is required to roll that out across the board. And it was particularly in the long position. And we'll discuss that a little bit later. So before the open trial, it's important to set the scene because I know anyone that comes from a different department can easily say, well, it was easy for you. You had three hospitals in the network and you had SGRT and you had all these bells and whistles. But just to set the scene, beforehand, we had three hospitals in the network, but they worked very independently nearly in some respects. So staff didn't mix. And when staff don't mix, generally they don't mix, bar a new job comes up, but as a routine, they don't mix. Um, I, and different techniques kind of creep in, or different methods of doing things, or like ways to overcome little challenges. So people worked a little bit differently in different areas. So there was variations in bolus management. In St. James's Hospital in Beaumont, we had a 3D printing bolus workflow that worked really well. Whereas in St. Luke's, they had a wax bolus. They had a mold room, specialist mold room that we didn't have in the newer parts of the network. So that was a big difference that we had to overcome. There was a difference in equipment and SGRT availability. So some LINACs have SGRT, others didn't. And we actually had different providers for masks, if you don't mind. So there was before we even started the trial, we even talked about randomizing, we had to standardize. So SGRT at the time, then in terms of staff experience, was only used for breast RT. We had dabbled with prostate, didn't have a great experience with it and pulled back. So staff had a limited experience of SGRT. So that was another barrier that we had to overcome. And then center specific immobilization techniques, in that some people had different types of equipment that they were all overcoming different challenges within their own specific department. There was different thresholds for replans and rescan. And from my personal point of view, before I even started the open trial, I started in the network in 2020, and it was a COVID time. I didn't actually meet many of the staff and the rest of the network. I'd never even been to St. Luke's and Rathgar or St. Luke's and James's. So Beaumont was all I knew. And then I started off in the fellowship and I had to rock down to different LINACs and introduce myself, and no one knew who I was from Adam. So I had a lot of trust to build up. before I even undertook in changing practices or even learning from what the different staff are doing and trying to solve those problems. So that was the landscape that we sat in before the open trial. And the big difference that allows us to be able to do and run the open trial was that we got surface guided radiotherapy. And like I said, we only were using it for breast patients. And in ways, you could say that it reduces the complexity of treatment setup in that we're not shifting from a reference point to an isocenter. But then anyone that's learning to use SGRT, they'd say it's a lot more complex. So there was a bit of a learning with that as well. But the huge difference that we had is that we could track patients' motion to within a millimeter accuracy live. And that kind of adds complexity, but it was a huge capability that was a new piece for us, and it could halt the beam exposure. And then it reduced the need for immobilization. That was the challenge. So it was the open trial allowed us to leverage these new technologies to maximize patient comfort and maintain treatment accuracy. And I suppose from a breast point of view, allowed us to remove those tattoos, which is a big win for a patient. And a lot of these developments that come with SGRT are massively patient focused, which is brilliant. And it really brings the radiation therapist to the fore in terms of research when it comes to SGRT. And it's a big piece with the open trial as well too was it allowed us to evaluate the new technologies of SGRT, which we hadn't done with breast or and with the trickier experience that we had with prostate. So it allowed us to build trust on it. And there's nothing like a trial to put discipline on a setup like that. So because you have to report on it afterwards, you make those decisions a little bit more carefully and you have future focused as well because you might be standing up presenting it someday. Um, when it comes to SGRT for head and neck patients, there are unique problems that we have to think about. Now, my experience again with SGRT was like everyone else in the network. It was breast, and I loved it, but I was really big into adapting new technologies, and I suppose you'd call me an early adapter in terms of tech. But I by no means knew what I was doing when I was trying to figure out this surface guided setup. And I relied a lot on Ruth Woods and Mags Tynan and all the experienced staff in the department. But again, we were all in the one boat. We didn't have a huge amount of experience. And the guidance from Align RT was no one else has done this before, but we'll help you figure it out. So I was kind of leading the way and trying to figure this out. And there was many an evening that we spent in James's trying to figure out what works best. And we actually ended up with a bit of a Goldilocks approach. So we started off with a big, massive ROI, and it was really quick and easy to set up and pop a patient on. But it was also averaging a huge area. And then when we went to image, it was an average of a whole lot of setup, and it was fast to set up, but it wasn't accurate when you had a lot of moves and the image quality. We weren't happy with the image match basically. And this is partially because it's a long PTV. So if you're trying to average over a face ROI and a thorax ROI, but there's a huge amount of movement that you can give between left and right there. And you only have one metric, I'll show you on the next slide, for a lat move. So it'll either say right or left, but what it really wants you to say is move the head right and move the thorax left. So that was a big challenge we had to overcome. And then the head and neck area of the body obviously has a whole lot more movement than a breast in that you can roll your shoulders back, you can flex your neck, you can rotate your head. There's so much movement that you're trying to reduce. And then the other area was if we had a huge ROI, it was averaging all the moves. So we were balancing mask coverage to make the mask stable, but also and keep that robust. But we also wanted an open area to allow SGRT to track intrafraction motion. So there was a lot of fine tuning and compromise in those early days. And we did a pilot with a small amount of patients. And it was first of all, we said we'd practice on each other, we'd take reference captures and designing ROIs. Then we brought it to a very small pilot with a few patients to figure out, is this working? Or do we need to pivot a little bit before we go to the full scale open trial? And then we moved on to a very scary start for the open trial. Well, it's hugely scary for me anyway. Kept the best side out when it came to the Ortiz. um, the other part of with ROI design was if you have a big ROI, it's going to limit sensitivity to movement in terms of interfraction motion. So a smaller ROI will be more accurate, and I'll go through that a little bit more later as well. So the guidance from SGRT on this you'll need good topography. Was the crux of it. So, and when you think about what good topography is, and we were used to setting up breast patients like you see here, it would be like putting an ROI underneath the breast, having those different slopes across the sternum so that that's flat, and then it might have a steep curve at the side of the the breast and in along the axilla. So an ROI should have suitable topography is what they would say, but then you'd ask what is good topography, and the head and neck ROI would have completely different topography than um, a breast ROI. And I'd love to say this paper came at the early days of the trial, but it didn't. It was very much it was well into the fellowship before we had the confidence to take this on. But we ended up asking, how do we measure good topography? And this came about because I was looking at, so first of all, when I worked clinically, I knew what good topography was just from being exposed to it. So if I said, this patient isn't setting up great, but that's because they are post mastectomy and their whole chest is flat, so it doesn't have enough to, I would say, and I'm sure other RTs say, enough to lock onto. I don't know what that's the lingo that came about. But what we wanted to say was we need more changes in direction, slope, angle, so that SGRT can capture that data. And then when I was looking, that worked fine clinically because we all knew it, and it worked for what we needed to do. But when it came to handling 200 patients and looking retrospectively at what ROIs were performing well and what ROIs weren't performing well, I knew looking at the setup and went to look at the patient to say, oh, that topography isn't great because maybe they had a higher BMI and their whole chest wall was flat, so there wasn't clavicles to lock onto. But to make that robust in terms of reporting and research, we had to measure what was good topography. So this is a little bit of a personal pivot from this. So I love to hike, and I'm from Tipperary, and there are wind turbines going up all over the place in Tipperary. And to measure where a wind turbine goes, they have to do an analysis of the landscape and to be able to say if this is an appropriate place to put the wind turbine, that the wind moves through it. Now, my experience on wind turbines isn't massive, but it was also the inspiration for this kind of trial. So then I was on this mountain where you see in the middle, and I was like, oh, it looks like a nose on an ROI. I was eat, sleeping, and breathing the open trial at the time. And then I thought they obviously can put a metric on this topography, and they know, someone in an office in Dublin knows that this area is mountainous and there is good topography in terms of SGRT. So then I was at an SGRT conference in London, and some of those conferences are so inspiring. And we were sitting at the back having a chat, myself and Kieran, and I said to him, can we use geographic measurements that they use for wind turbines on our SGRT surfaces? And Kieran never says no. He's like, we can figure it out. So we come up with the idea, and then Kieran put this genius that he is, Kieran Malone, he's a physicist in St. Luke's, and he's doing his PhD at the minute, came up with a synthetic surface that we could test this. So I went frantically Googling and came up with what the geographic experts in wind turbines and wind engineers use. So there was three measurements. There's vector ruggedness in measurement, topography position index, and terrain ruggedness index. So I'll run you through some of these now, but I don't want to spend too much time on it because I'm conscious that there's a lot to get through with the open trial. But this is a paper that I really, really loved with the open trial, and it was so innovative. So if you're on a mountain and vector ruggedness index is the measure that you're looking at, if you imagine that you're there on that mountain, you look down at your feet. If you're in Kilimanjaro or Croagh Patrick and it's a rocky, rugged terrain that there are lots of stones underfoot, then you have a high VRM. And if you are in the Galties and or the Alps, so you look under your feet and it's grassy, smooth terrain, then you have a low VRM. And when you bring that back to a patient, you could look at that and say that's scar tissue. That's a lumpy surface on the patient's skin, or you could look at it as a hairy chest or a beard on a face as well too. So that was one measurement that they used in geography that we brought back to our surface, and it wasn't that useful in terms that it's not something that we came across that much, but it was something that we took account into the paper, and there's a QR code for the paper at the top there. And then the topography position index is like if you were on in the Alps where it's lots and lots of peaks and troughs versus if you're on the Curragh of Kildare and it's a smooth surface. That's the measurement that you could use. And when you bring that back to the surface topography, the Alps with lots of peaks is your face or Y where you have nose, eyes, dips, mouth. And then your Curragh of Kildare is your post-mastectomy chest wall. And they're the kind of measurements that we used. And then I suppose the terrain ruggedness index is if you're sitting at the bottom of a mountain looking up and it tells you your position where you are. So if you're talking about a point on a patient's surface and it's at the very inside of the eye, you have a low terrain ruggedness index and a high. And then if you're on the peak, obviously you have a high terrain ruggedness index. So that's a little bit of an overview on how we developed a metric for measuring surfaces. And then in terms of methodology, we created synthetic surfaces so that it was a known amount of peak or trough, and then we tested that, and then we moved on to actual SGRT surfaces. So we used breast patients for like that smoother surface, but we also tested a head and neck or wise. And I jumped onto the bed, took a reference capture of me, and then analyzed my topography on my face. So you can look at that paper in your own time. Sorry, I'm very conscious of time here. So when it came to designing the actual setup for the open trial, we looked at having our first approach was a huge, big, like I said, surface, but it wasn't accurate enough. Then we developed a technique where we had a face ROI and a composite or a chest ROI, but we were moving between the two. It was a really accurate setup, but to set the patient up, it was taking ages because you were moving between face and running over to go back to the thorax. And so then the final Goldilocks perfect porridge situation ended up being that we had a face ROI. And when you're setting that patient up, that face ROI is a setup ROI, and you're getting the patient to 0, 0, 0 on your vert, long, and lat. You can see that image and your rotations. And then you're moving to your composite ROI. And the composite ROI is a face ROI and a thorax ROI. So you know when you turn that on, if your face ROI is 0, 0, 0, any outstanding error there is on the thorax. So then you can move the patient's shoulders or adjust the bed in that way. Now, this isn't something that you can pop down on the unit and learn overnight. There is definitely a learning curve with this, and RTs will tell you that when they started, it was tricky, and as they build confidence, they get better and faster with it. But I think that's the way radiotherapy is with advancing techniques in terms of SGRT anyway. Building confidence and skill with the skill of using SGRT is going to be part and parcel of how we move forward. And then in terms of if anyone's looking at trying this themselves, we set up at a 2 mil on the deltas and 2 degrees on the deltas as well. And if you're doing it yourselves, it's a setup ROI for the face and it's an isocentric ROI for the composite ROI. And that allows you to treat with beam control. If anybody needs, I'm happy to be contacted afterwards if anybody needs a further in-depth overview of that as well. Back to the open trial. So then it was the largest RTC for open face masks, and even when we brought it to ESTRO, it was still the largest trial analysing open face masks versus closed. And it included radical RT for head and neck cancer patients. We kept the exclusion criteria massively wide to get it done quickly and to give patients an opportunity to engage with the trial. But there was the exclusion criteria of claustrophobia. And we kind of struggled with this when we were designing the trial as well, so that we wanted patients to be able to access an open face mask, but we needed them to be able to tolerate being randomized to a closed mask. So they were randomized 1:1:1, and we used frequentist and Bayesian statistics as well too. And I'll go through the claustrophobia thing will come up later. Here's all the photos of me. So this is the control arm. This is a closed mask, an Orford Industries mask, and like can see, it is quite claustrophobic. And all patients were treated with daily online imaging, CBCT. And this part of the trial didn't use SGRT. Obviously, there was nothing to track, so SGRT wasn't used. This arm B is a combination of a 3-point open mask, and we used SGRT and again had daily CBCT imaging. So the 3-point open mask had the ROI that we saw in the earlier slide, and it was on my thorax and my face. And you can see this mask is open on the face, but also the whole chest is open. Now it's tracked, but it is open. And then the final arm is a 5-point mask. So this is kind of the halfway house. It was open on the face, and we had a restricted area of opening on the thorax, but we still had the frame on the shoulders. And also to say, on arm B, there was shoulder retractors used. They caused problems, and if there is definitely better solutions, but I can go into that later in the problems that came across. The open trial endpoints then were, the first primary endpoint was to compare setup accuracy of the 3 masks and the SGRT combination. The secondary objectives were to compare patients' distress levels at the beginning and the end of treatment. And we used a GHQ questionnaire, so it's a 12 question questionnaire. And we also added additional questions on comfort, tolerability, and overall experience. And the reason for that was, obviously, head and neck patients, there is myriad of reasons why they might be distressed in terms of side effects or difficulty swallowing, eating, etc. And then, oh yeah, so adding those 3 questions at the end kind of mitigated, well, it was our attempt at mitigating all those other confounding factors. And it actually proved beneficial in the end. And then the next secondary objective was to evaluate the potential advantages of surface guided radiotherapy as a tool for interfraction motion monitoring compared to cone beam CT. Again, I'll discuss later. And the third was, and I think it's so important to keep any of these trials for them to be clinically relevant, to acknowledge the resource limitations that there are. And that is the third objective then, was to assess the impact on treatment setup time and the use of resources on the treatment unit. And I just also, throughout this, the staff in the department were so helpful, and they really got on board to help us with any of these problems that we were coming across. And yeah, it sometimes took longer, and our trial staff had to go down and consent patients and administer these questionnaires, but the resources that we got from the whole Luke's network were amazing. They really got behind us. PPI was also a really important part of the trial design. And we got a patient, Anthony, in to view our documentation at the start. I know there's a really interesting learning. Now, I do think he was an exceptional patient. He was into marathon running and long distance cycling. So, and he'd raised lots of money for Luke's. But he was a tough nut, and he also had the mentality that if it's harder, it's better. So he kind of gave us that new perspective to say, okay, if you're giving me the easy option, then maybe it's not as good. So that was a really new learning. So we had to change our documentation to say that you're getting extra tracking in terms of surface guided, because we had left our documents very much about the mask itself. So that was a new learning. And also, I suppose patients are not prepared to trade safety for comfort. So that was huge. Yeah. He was an interesting patient as well too. And we got him back afterwards as well too. So the additional safety checkpoint, we brought that into the documentation as well to say weekly pre and post cone beam CT were used to assess interfraction motion. There was a safety checkpoint that we built into the design of the study. And then in terms of the demographics, so we had oral cavity, larynx, skin, hypopharynx. So like we said, we kept the exclusion criteria very small, and the inclusion criteria exceptionally wide. And it was RTT and trial coordinator led consent. That was a new thing for us and Luke's as well too. And the trial accrual came to 230, and the period of accrual was January 24 to April 2025. This consort diagram shows the 3 arms, and it's all the usual reasons for patients will be excluded that we weren't expecting and the design, but progression of disease was one. And the big thing I want to showcase here is arm A had 6 patients that couldn't tolerate the mask, and this was a non-claustrophobic cohort of patients. So patients had initially said that I'm not claustrophobic, and then we put the mask on them and they couldn't tolerate it and found a whole new area of claustrophobia. And that then in arms B and C are 2 open face masks. We had no patients who couldn't tolerate the mask. So that in itself was a learning. And actually that at the start of the trial, we did anticipate that we might have patients who thought they weren't claustrophobic when we put the mask on would learn that they actually were quite claustrophobic. And the primary endpoint, intrafracture motion. So this was measured using CBCT and that traditional way. And this is actually a good learning if anyone is taking on any kind of trial. So when it came to ethics, we originally wanted to do our cone beam CT at the start of treatment and at the end of treatment. So that would mean an extra radiation exposure for the patients. But it was after the treatment was delivered, so we actually couldn't action it. And to overcome that with our ethics application, we had our first cone beam CT at the start of treatment, but we moved the second cone beam CT to between the 2 treatment arcs. So that meant that we imaged, treat the first arc, imaged again, and then we could apply those moves after the second arc if there was moves, and then the patient would benefit to have that extra level of accuracy then as well. So that's how we overcame that in terms of ethics as well. And that was for that safety checkpoint as well. But reassuringly, there was no significant difference across the vert and lat rotation between the 3 arms, and the median setup errors were very, very small, less than 1 millimeter, and not clinically significant when it comes to a 3 millimeter margin. But the long direction did show a significantly different or significant difference even, but it was not clinically significant. The difference didn't translate to a differing PTV at all. So again, reassuring, and that the difference in the long was actually in our closed arm, our conventional, and our arm A. So that closed mask. So the 2 open masks outperformed the closed one in that. Now, again, not enough to change the PTV margin. Sorry there. Then the other area that we assessed, intrafracture motion, this was a new area for us. So we looked at those same 56 patients, and we had the cone beam CT at the start, but we also had SGRT during, and then we had that cone beam CT at the end as well. So intrafracture motion assessed both weekly pre and post CBCT, or by pre and post CBCT. There was daily online cone beam, but twice a week, twice cone beamed once a week, if that makes sense, and daily SGRT. So I think it's really important to highlight here that our CBCT matched bony anatomy, whereas our SGRT matched surface anatomy. So they weren't looking at the same things, but they both showed very small movement. So cone beam CT deviations and translation rotation based on bony alignment, like I said, and then SGRT as continuous monitoring of the surface. And we used a Bayesian analysis to determine the equivalence across mask types and measurement techniques. I'll come back to that as well too. So open face masks show that intrafraction stability are comparable across closed arms, and the mean CBCT difference was 0.4 millimeters and 2 degrees. SGRT ended up being in the 95th percentile of deviations of 0.4 and 0.8 degrees. CBCT interfraction margins were again really reassuring, 1.8, 1.7, and 1.3. And then SGRT obviously did pick up transient deviations that cone beams would have missed, because cone beam CT is that snapshot in time at the start and end of an arc, whereas SGRT is a continuous monitoring. And the confidence that SGRT was allowing us to capture patient position variation when it mattered most, in that while the beam was on, whereas SGRT wasn't a beam on treatment time. And then I'm very conscious of time as well too, so there is a little QR code here that you can scan to see that paper that runs through that in more detail. Then patient experience, I had mentioned that we did a GHQ questionnaire. I need to highlight that none of the fellows had taken part in any kind of research that was anyway qualitative before. So this was a new area for us, and we did lean heavily on the psych onc department in St. Luke's here. Um, so they used a GHQ questionnaire that was used within research previously on head and neck populations, but also like there was papers that used it on hospital staff during COVID. So it was widely used, and the threshold for distress was 14 on that scale, and we had a 91% return rate in that questionnaire, and that the trial coordinators were brilliant in keeping on touch of that. It's also important to say when you're doing a trial in a hospital like this where it's really busy and resources are tight, you have to be pragmatic in your trial design. So initially we had said day one of treatment and the last day of treatment that you'd have this questionnaire, but to be pragmatic about it, we used the first week of treatment and the last week of treatment so that the trial coordinators had a little bit more time to get down to the patient if to administer the questionnaire. Also, we kept a big emphasis on sustainability in the trial as well too. So we kept them all online, and all our masks were biodegradable as well. So the open mask showed the lowest level of distress, and 5-point open so it showed that significant lower levels of distress at the start and at the end of treatment. Both open arms had significantly less distress at both the start and the end, and the closed mask showed the highest or the largest increase from the start to the end. Now, for RTs that are on this call, we'll be highly aware that like if you show a patient a huge big mask with no opening on it, it's intimidating at the start of treatment, and that kind of feeling permeates through the whole first week that it's a scary concept. Um, and we would have always said that patients get used to it, but our research shows that they don't, that the distress it stays with them for the whole course of treatment. You don't actually get used to it. And then also an open mask, especially a 3-point open mask, is smaller, it's less intimidating, and it's very intuitive that that would have a lower level of distress. And I think that you can open your eyes as well too is huge when you chat to patients. That was a big thing, that opening their eyes was important for them. Not so much when you're tracking with SGRT, but that was it was a good learning from it. Then we looked at the 3 different questionnaires that are questions that we added at the end that were specific to the mask. So, like I said, the GHQ questionnaire is very broad, and we were concerned about that at trial design. So we added these 3 questions on tolerability, comfort, and overall experience and overarching questions. So the closed mask had the worst rating at the start and at the end. They showed no improvement. So patients didn't get used to it. A 3-point open mask showed better tolerability and overall experience, both at the start and the end of treatment versus the closed mask. And that's, you can see on the image to the side, red being negative, green positive, and we actually had neutral in that as well too. And then the 5-point open mask improved from start to the end of treatment. They showed better comfort and tolerability, and the experience at the end was better for them. That overall experience. So resource utilization, I think this is really important to include. So the average number of cone beam CTs per arm was 1.1. There was no difference demonstrating that resetup rates due to mask type was comparable. Then the number of masks related to replans were highest in the closed, and we knew that would, well, we didn't know that would happen. But it is afterwards that it wasn't a surprise. At the start, it could have been that the 3-point masks were rescanned more because they weren't setting up well, but that actually didn't transpire. That the 3-point masks were we were better able to manage weight loss or weight gain or swelling or any of those kind of issues because we could move an SGRT surface. And that in itself is a huge big skill that we can have because masks are rigid and you're messing with shrinking and cutting out bits of masks. But when you can adapt an SGRT surface and image to validate, that is a huge big skill that we it's a big advantage to having the SGRT. And it's also important to show that this is a non-claustrophobic population, but we still had that change in mask with mask intolerance. So patients that were scanned with a closed mask couldn't tolerate it and were moved to an open mask. They came off trial for that reason. And that was 7%, but that was a population that said they weren't claustrophobic. And then resource utilization. This I think is a really there's a lot in this in the full paper that's coming, but I think this is useful for RTs specifically, that this is a whole new way of setting up a patient with two ROIs that we've never used before, and there is definitely a learning curve within a patient, but within a department as well. So within a department, we all have to learn how to use two ROIs on a very movable area of the body, but it's hugely personalized to a patient as well. So at the start of treatment, we spend a little bit longer adjusting an ROI. So when you have a plan down, you see a patient and hairy chest or a brighter skin complexion on the face than on the chest. So if they're wearing a shirt and they're not getting as much skin exposure, it's pale Irish population. So we had issues like that. And at the start of treatment, you have to adapt the ROI or learn how that patient basically works with that setup. So you can see at the start of a session or the session in time that we take a little bit longer, but as we settle into treatment, we get used to setting up that patient and the little quirks that come with it. Now, you could say that RTs have to treat the same patients all the time, but it's not so much that. And like that is an advantage if you have the same RTs every day, but that's always been an advantage. But it's more their ROI and their setup, and also patient getting used to it as well too, because we're definitely touching a patient a lot more than if we were just putting on a mask. So the first few fractions took longer, personalization of ROIs, but quickly settled down to that dotted line you can see there to 12.5 minutes. So no obvious difference between the 3 and 5 point masks. The open trial, so it showed mask as a bit of a conclusion. So masks, open masks were superior, improved patient experience, equivalent setup accuracy, reduced replanning rates, and that is due to less mask, less with more adaptation of SGRT, no significant impact on LINAC capacity, and a new standard of care for head and neck cancer. Potential huge benefits then, especially for pediatric patients. You can see how that would make sense. So, more quotes from patients again, on the closed mask. So, mask was so tight I couldn't breathe through my mouth. Breathing using nose instead took a while to get used to. Was panicking the first 2 days, but got used to it by day 3. Hard to tolerate. Sometimes it is unbreathable. Whereas the open mask, I got one of the one with the open face. It's brilliant. It's very easy. I was amazed at how easy it was. Now, it's also important to say that no patient had the experience of all three. So, and this whole research project didn't come about with a small team. It was a huge team, and we had so much help from all these different organizations, from the St. Luke's Institute of Cancer Research to the Research Fund, Friends of St. Luke's, HRB, Trinity College, Orphan Industries, Cancer Trials Ireland, SGRT. You could go on and on and on. And that's just the organizations, the individuals at the back of all those organizations. It was such a team effort. Nothing was ever too much of an ask, from the trial coordinators to any of the radiation therapists in St. Luke's. And I am so, so grateful to all those RTs that got behind me and helped in any way they could. They were absolutely brilliant. And then obviously the doctors in St. Luke's, and even the patients that got involved in PPI, and Ruth Woods, and any of the mentors that I had along the way. I would not have been able to do it without them. But I do want to say that everyone is capable of something like this. Like when I started the fellowship, I had no real experience of running a trial. I asked 100,000 questions and I got so used to hearing no. And I think from my experience, sometimes RTs come up with good ideas and then they get told no, and then they're dejected or they're a little bit like, oh, I won't ask again. But it's to stay asking, because departments have competing priorities, and maybe it's not that first good idea we have, but there will be loads of good ideas. And it's to build relationships and speak to the right people, but don't get disheartened. And if you get an opportunity like a research mentorship program or a fellowship or anything like that, please, please jump at it, because what I got from it, I couldn't even begin to tell you how amazing it was for me. And I know there was so much work there, but it was between 2023 and 2025. Don't be overwhelmed. If I can do it, anyone can do it. And like if I can support anyone in taking on something like that, I'm more than happy to be contacted for that with that. One of the big things that I learned with the open trial was overcoming barriers to change. And I completely get it. There's so many people that are working, and they've so many patients coming at them. There's so many different techniques, new technologies coming, and here's me looking, sorry, can I actually get on the unit, or can I ask you to do this differently, or they haven't got time, there's financial constraints. And I think that's the biggest barrier in implementing something like this. And I think for myself, the solution was people, and to build relationships with people and to bring people on board. And to give them the opportunities that you have a little bit as well too. So I was so lucky to get involved in the fellowship. But if they wanted in, or if they were interested, to give them that opportunity, and build a little bit of buy-in as well. And obviously give people the credit for the work that they do, I think is huge as well. What's next? The path forward. Um, Patients were happy with the open face masks. And if you go to Estro, or if you're in that big radiation therapy community, there's so much hype about no mask solution. And is that the right thing to do? Do we pursue no mask? Do we lengthen the length of treatment to allow that level of comfort for patients? Or do we stay where we are in terms of an open face mask? And do we work on reducing margins? And this is a question that we're facing in Luke's and within the radiotherapy community in general. And I don't have the answer for you, but it is a really interesting kind of crossroads that we're in. There are studies looking at no mask. Um, but is there a better return on investment if we look at reducing margins for patients or increasing accuracy? And I'm popping this slide up again, just in acknowledgement of all the help that we got from the fellowship. The three fellows, Jill and Kieran, were amazing, and they're still on their fellowships and looking to wrap up in the next little while. And I think we can all say that my experience working with Jill and Kieran was fantastic, and the two brightest minds I have, I'm in all of them, and honoured to be able to work with them. And this whole group have been amazing. I'm happy to take any questions if anyone has any. Um, I've run a little bit over time. Sorry, Laura.
That's fine, Samantha. Wow. It's incredible. You know, you sit down and you read a paper and you get the findings from it, but you really pull back the curtain on all your learning from this trial, and it's invaluable. I think for Ortiz particularly, we're interested in the practical implications, and you
Yeah.
had so much in that presentation to share with us. Thank you so much. It's full of
It's
advice.
a whistle stop tour, but there is so much in it. Like, it was 3 years of fumbling about and learning and learning and learning.
But really practical. Yeah, that was really, I found that really, really interesting. Thank you so much. Um, yeah, and really useful, I feel, for people working clinically. Yeah, wonderful.
And like, it's only touching the surface. If there is any questions on the clinical aspects of that, we're still figuring things out. And I'm so happy to engage with people who are trying to do something similar, because I'm learning from it as well too.
And I guess,
And to say, when I was looking at that head and neck setup, I was on LinkedIn reaching out to Ortiz in Finland and England, and I was a pest to people. So please pester me.
that's the beauty of it. It's you had that multidisciplinary team. We talk about Kieran, physicist, Jill, radiation oncologist, working together, finding out what people have done before, using your networks to help
Yeah.
you on this journey. Because some people maybe have gone before, or people on the same journey with you, and sharing those experiences was, I'm sure, very useful for you. I have a whole pile of questions. I might throw one or two. It's funny from what you've said, the importance of having that preliminary training before you actually open the trial, because, you know, practicing, getting kind of techniques nailed, your ROIs, all that I imagine would have impact on the trial results inadvertently, maybe because it's quite a steeply learning curve, but having some of that done before the trial actually opens, I imagine was very invaluable to you.
Oh, huge. Yeah. And actually, to be honest, at the start, some of the like Sinead Brennan and them that didn't they hadn't used SGRT, they didn't know. They were like, okay, so we can just start with the head and necks. And I was like, absolutely not. I don't know how to do that. Like I need to figure that out. So Ruth and Mags were brilliant to like we had our own little team of how we were going to figure this out and bang heads together to come up with that. But if you hadn't done that work, I like the open trial wouldn't have been a touch of the success that it was. And that we probably could have done more. We could have done more practice with it. I feel like the RTs that engaged in the or worked on the open trial, they would have been delighted with more. So,
Yeah, and I guess it's a fine balance, isn't it? Getting ready and then needing to launch
yeah.
and get that ready as well. And I guess what I really love from it is that the really interesting aspect of the PPI, having Martin, I think the patient you named, having him involved in that completely different view of, I'm not gonna, if it's tough, that's fine because I know it's correct and I'm willing to go through.
Yeah. Yeah.
Really
And
insightful.
it's funny that the patient that we ended up picking had that view because I feel like a lot of patients didn't, but it was a completely different.
Mm.
We were so focused on the anxiety and the stress. And I think when you're in designing a trial and you're in that little bubble, it's really good to have an outside perspective. It's invaluable. And every trial should have it.
Yeah, and they can teach us so much from the
Yeah.
way they that, we think we understand them, but actually we don't at
And
all.
it would have been nice as well, like if you to bring that co-design element, you could definitely do more with PPI on this, definitely. Yeah.
Okay, I'm going to put some of the questions from the audience if that's okay. So, question here, just wondering, what was the rationale for the open mask on the thorax, as you would have thought the anxiety was related to the face only?
Um, well, yeah, you could say the anxiety is related to the face, but definitely there was a difference. Like the preference was the 3 point mask. So we showed that that the thorax being pinned down and chest being pinned down, um, was a different confounding factor that they found that as stressful. But to be honest, the resource implication, we were taking on this huge big trial. And if the open trial failed and the 3 point mask was worse than the
Mhm.
standard of care, we needed a halfway house. We needed a fallback. So being really honest about it, we had three arms because we had our shoot for the stars, our 3 point mask, and our standard of care, but we needed a safety net.
Okay. Another
Yeah.
question, have you any special innovations for patients that have lots of hair and how they might obstruct good immobilization in the mask?
I'm so obviously the best case scenario is to get rid of the hair. So we're not if there's a whole big lot of dreadlocks, it's definitely going to impact the position on curve board or a head position. But you can actually do so much with ROIs. And I think building confidence and playing with ROIs, actually that first pilot that we did, we had one patient who had a horrendous chemo reaction and swelled up hugely. And he was in a 3 point mask. And if he was in a standard mask, we wouldn't have been able to get the mask on him. He wouldn't have been able to finish his treatment. Well, he wouldn't need replan, rescan. But his swelling was changing day to day on his neck, on his chin, everywhere. So we could actually adapt the ROI and put it on his shoulders, put it on his clavicles, and as the adapt for where the swelling was. If it was off his chin, we were putting it on his chin. And if you have tricky setups, like I've had patients before with full heads of dreadlocks, that you can change the ROIs. And the 3 point mask allows you to have that flexibility. Now, it takes a little bit of confidence with SURT and it takes a little bit of figuring out. But if that one patient isn't getting rid of the dreadlocks, it's definitely an option.
Another great thank you, Samantha, for a very insightful overview of the study. Could I ask you included patient quotes at the end of your presentation from across three arms? Was there any qualitative exploring of patient experiences beyond the qualitative questions you asked in the GHQ-12 survey?
There was. I didn't do it. Roisin and Whaley, she's here in that picture on the extreme left. She did a focus group. Now I don't know I don't think she has it published, but I will pester her to publish it. And maybe contact Roisin as well too, because she did a little bit of work on the focus group, and got some of the open patients involved, and she used that for her masters as well. So yeah, that box is technically ticked.
Great, watch this space. And then I might ask another, oh, sorry, there's another question come in. I might ask a quick question. Oh, there's a load there, sorry, but then I won't ask a question. Thanks for a wonderful presentation. What aspects of the trial QA were you involved in as an RTT?
In terms of, so I was involved in the whole design of the trial, but we like there were parts that we had to. So SGRT, in terms of QA, SGRT was done. But when I designed that set up with the face and the thorax, we had to do a lot of validation on that, and it was practicing and practicing and practicing. But the topography work was kind of forming that QA, because when someone says, how do you know that ROI is accurate? We didn't really have an answer for that, because the guidance from SGRT was use good topography. But then when I looked at the differences in setup accuracy, it ended up being that they didn't have enough topography. That elevated BMI across the chest was a problem. So when we were working through it, we had to validate as we were kind of like the next set publication was interfraction motion. We had that safety checkpoint, and we published that. So that was another safety checkpoint, and it happened to be a paper. But the topography one was answering that question, like why is your, or why is it validated? That topography paper validated that as well too. So we were going along, as we were going along, we did part of that. Um, and any opportunity we had for increasing safety, we did. We had daily imaging, and once a week, twice daily imaging. So but actually the QA of SGRT, that was all done before we started the trial. Obviously with implementing SGRT. Yeah.
Okay.
Sorry, I know did I answer that question. If they want to ask me
If
again
you
after
want,
that.
if you want to come back on that, let us know. Another question. You touched on the shoulder tractor to help immobilize the shoulders. Your ROIs did not include the shoulders. How did you ensure that the shoulder position was accurate and did not impact on the setup and the CTV volume position?
So the ROI comes across the chest and includes, like, say, up around the clavicles. So in theory, that would show you have to get those areas in tolerance, you need to pull the shoulders down. So, and when you look at SGRT, you use your postural video and you can see shoulder position on that. Now, that said, any of those patients that had a very big BMI, where you didn't have the topography to be able to put that in the right position, we actually did put ROI over onto the shoulders. And also the other thing is you really have to personalize the ROI to the patient that's in front of you. So if it's a thing that you think you need an ROI going off out to the shoulders, I just showed you one patient, do feel comfortable doing that, and that's that at the time resource utilization to personalize the ROI for the patient that's in front of you. You take that time to do that at the start of their treatment. Sorry, I should go into the shoulder retractors a little bit more. We use shoulder retractors because we were patching up equipment between Luke's, Beaumont, and James's. The orphan industries have arm poles that will be better than shoulder retractors, but we didn't have that in Beaumont and James's, and you could have used them in Luke's. But there's definitely you could do to make the shoulder positioning better. Like I've played with vac or with mold care cushions and vac bags. There's absolutely more you could do there,
Okay.
and play with your SGRT.
My last question, just about the results. So you mentioned the closed mask in the long dimension that was significantly different, or
Yeah, but
was
not enough to impact a PTV. Yeah.
not in fact. What's your, have you any theory of why the closed mask, the long position was different?
Because I think when you're setting up a patient and
Yeah.
you have the headrest to show the curvature, and maybe you have the shape of the nose on a
Those,
mask,
yeah.
but a patient can move up and down on that within that mask. And I think if there's pressure on the nose, they'll move up and they will move down. So they'll wiggle within that. But SGRT stops you. You don't have to wiggle, and SGRT tracks that, if you get me. And it was the same when we didn't have SGRT on Ashling Glynn's study that happened before I started the trial. It was the long position. And
And
also, anyone taking on something like the open trial, your headrests are so, so important
mm. And I
because
went, so it was the SGRT monitoring that motion during
Yeah.
treatment, you're able to correct for that you weren't
Yeah,
able
so it's not just the mask, and that's why when we're talking, I'm writing the paper now with Jill and Kieran and Sinead, and we're talking about mask, but it's actually more immobilization system. It's mask and SRT in combination.
Yeah. Okay, so we're about 1 minute over. Samantha, thank you so much. And I guess I love the topography paper. I think it's something that anyone using SRT is probably a must read for them. But that out of the box thinking that it was when you were up in the mountain that came to
Yeah.
you. We were just chatting about it
And
before
when
it started about
Yeah, and when you're reading that paper, it's important. Like it's not massively physicsy. Like it's very relatable for RTs as well too, which is great. And that's the feedback we've gotten when we wrote that paper as well too. That it's not hugely physicsy because it's so like physicists weren't involved in wind turbines either. Like so, so it's a whole new realm as well too. So
yeah, but about thinking about, that
different
sometimes you think
industries.
about different things, and we were chatting with our folks started about out of the box and different disciplines, how they can actually add value to what we're doing, even
But that isn't a new thing. Like when you think about QA and SGRT, we always go back to aviation. Or QA and RT, we always go back to aviation. So yeah, it's not a new realm.
Great. Well, thank you very much, Samantha.
Thanks,
This
Laura.
video will be online probably in the coming days. And if anyone wants to access it, feel free to do so. Okay, Samantha, wonderful chat. Thank you very much
Thank you so much, guys.
for insights
Um,
and sharing
and
them
if
with
anybody wants to reach out to me on LinkedIn, because I know it's tricky trying to do any of these things themselves, and I pesters people. So
us. On that
thank
note, thank
you,
you,
guys.
everybody. Bye.
Best bye.